¿Qué tal? Bonita mañana a todos. Bienvenidos a un nuevo webinario de este ECMO V-V Summit, Desafíos y Nuevos Horizontes. Estamos llegando al tercer webinar con todos ustedes emocionadísimos porque nosotros podemos tener esta oportunidad de aprender de increíbles expertos. Y el día de hoy tenemos este increíble ponente que les voy a presentar, que para mí es un honor verdaderamente que esté aquí con nosotros. Él es el doctor Matthieu Schmidt. Nada más y nada menos que la mano derecha del doctor Alain Combs en el Hospital La Pitié-Salpêtrière en París, Francia. El doctor, les cuento un poquito de él. Él ha sido incluso presidente del Comité Científico de Orelso, más o menos del 2018 al 2022. Es miembro también del Grupo de Investigación Educativa ECMO-E de ELSO desde el 2018. Forma parte también del Comité Red REVA desde el 2015. Es parte del Comité Científico de ECMONET, la Sociedad Francesa de Reanimación, SIM. Es investigador principal de múltiples ensayos que seguramente muchas de sus publicaciones las han visto. Él ha generado ensayos clínicos multicéntricos aleatorizados como PRONECMO, Dressing ECMO, Corium. Es revisor de muchas revistas como la American Journal Respiratory and Critical Medicine, Lancet Respiratory, Care Medicine. Realmente él tiene más de 235 publicaciones y obviamente sus principales intereses son investigar mucho acerca de ECMO. Así que para mí es un honor tenerlo aquí con nosotros. Y el día de hoy vamos a hablar acerca del tema ventilación mecánica en ECMO, que yo sé que es un tema angular en el manejo de este tipo de pacientes, que yo siempre hay muchas preguntas en torno a esto. Así que créanme que es un honor para nosotros, para la academia, Healthcare Training Experience y también para nuestros colaboradores, el INER, el AFTR, que siempre están acompañándonos, y la Sociedad Mexicana de Neumología y Cirugía de Tórax, tener ponentes tan importantes como él. Así que démosle la bienvenida al doctor. Por favor, les vamos a dejar en el chat. Tienen un canal de interpretación, dado que la ponencia va a ser en inglés. Tenemos un intérprete que es doctor también, es el doctor Moreno, nos va a estar apoyando a hacer la interpretación simultánea. Así que todos, por favor, si quieren escuchar la ponencia en español, tienen que poner en su canal en español. Tienen que poner que seleccionen la interpretación en español. Los que quieran escuchar la ponencia en el idioma original, que va a ser en inglés, pueden dejarlo en inglés y van a escuchar al doctor Matthieu Schmidt en el idioma original. Les pedimos a todos que nos apoyen con eso y que nos regalen en el chat desde dónde se están conectando, cuál es su especialidad. Nos encantaría mucho saber desde qué país están conectando, y todas las preguntas recuerden que van a estar en el Q&A. Entonces, sin más, le voy a dejar el foro al doctor Matthieu Schmidt. Welcome, professor. Thank you very much for being here and sharing with us all your experience in La Pitié. Thank you.
Thank you very much. Good morning, good afternoon. I don't know exactly what time is it in Mexico, but thank you very much for your invitation to talk with you about mechanical ventilation on ECMO. And as Jennifer already said to you, it's clearly a very important point when you are managing a patient on VV ECMO. So it means that if you don't pay attention to mechanical ventilation when you are doing ECMO, I think it's quite useless to do ECMO. So it means that it's a very important part of the management. So here are my disclosure with some company who are designing and who are working with extracorporeal support. So to introduce the talk, I will just remind you that even if you religiously apply mechanical ventilation guidelines, meaning by strictly applying 6 ml per kilogram ideal body weight tidal volume, by applying IPEEP, by paying attention to control the plateau pressure as well, you see with my arrow that there are some patients who still exhibit some red spot if you do a CT scan. And this red spot will show you that there is what is so-called tidal hyperinflation, which means that despite applying what is called protective mechanical ventilation, despite using this low tidal volume, this control PEEP, the control the plateau pressure, you are still deleterious for some patient, probably the one with the smallest baby lung. You are still doing what is called tidal hyperinflation, which is another distortion of the safe zone, of the very small space of normal lungs. You are still deleterious with them. And this is a CT analysis, CT study, but if you look into the bronchoalveolar lavage to see exactly what is the local inflammation in the alveoli, you see that for those patients who were called less protected, meaning those who got tidal hyperinflation, all of these patients got a very high level of inflammatory markers in the bronchoalveolar lavage, meaning that the local inflammation in the alveoli is very intense for this patient who are still exhibiting a deleterious mechanical ventilation. So the underlying message of that is quite straightforward. In fact, the smaller the baby lung, the greater is the potential for unsafe mechanical ventilation. So we have to clearly pay attention to mechanical ventilation in this context, because this population, this subpopulation with a very small baby lung will be ECMO patient with a profound lung damage. So the principle of VV ECMO, it's to replace pulmonary function. This is a very visual effect. You will have a normalized ABG, you will have a good PO2, good POCO2 as well. But do not forget that it works, it saves lives, not because you are replacing pulmonary function. Obviously, it's part of the job, but it will work mainly because you will allow the lung to rest. So it means that you will stop aggressing the lungs with deleterious mechanical ventilation, because most of the gas exchange are ensured by the ECMO device, so you don't need mechanical ventilation anymore, or at least you need partially, you need a partial, you need only very partial mechanical ventilation as a very partial place, small place into gas exchange, because most of the gas exchanges are done with the ECMO device. So with this device, we will allow the lung to rest, and we will get time to allow healing of the lung and to be sure that the primary disease, which could be COVID-19, influenza, bacterial infection, are solved with a specific treatment. So with VV ECMO, we will buy time to wait for the healing of the lung. And during that time, we have to find a way to treat the baby lung gently. And for that, you need to go back to physiology and to focus on what are deleterious in mechanical ventilation for the lungs. And we have more than, let's say, 2 decades or even 3 decades of research in that field, which has progressively shown that what is participating to what is called decreased ventilator-induced lung injury, VILI, we know that the volume is toxic, the barotrauma, the pressure is toxic as well for the alveoli. You have the phenomenon of atelic trauma, which is a collapse of the alveoli at the end of the expiration, followed by an abrupt surdistinction of the alveoli. And we have the biotrauma, which is also the release of lots of cytokines, inflammatory markers into the blood, which may lead to exacerbate the inflammation. And there is another point that we have also to take into account, is that this population on VV ECMO will be ventilated for probably a prolonged time. So we need at some point to prevent what is called myotrauma. Myotrauma is the fact that your respiratory muscles are not working at all during a prolonged period, and rapidly we will see atrophy of this respiratory muscle, with the primary one being the diaphragm. And this prolonged ventilation with rapid muscle atrophy may prolong the weaning of mechanical ventilation. So at some point, we need also to let our patient breathe spontaneously. So what's going to be the point on VV? The point will be to markedly reduce what is called mechanical power. So mechanical power, you know, it's a very complex equation described by Luciano Gattinoni, which express in the same equation what is the energy transmitted from the mechanical ventilation into the lungs. And we have shown in this international network, when we follow day by day mechanical ventilation for those patients on ECMO, you see that before being on ECMO, mechanical power is very intense because the severity of the patient is very high, and you need to ensure gas exchanges. And as soon as you start a V-V ECMO, mechanical power will decrease by 75%. And in that situation, you are resting the lung, in fact, because you are decreasing mechanical power. And on the right there, when you are after ECMO removal, when you have a successful removal, you see that mechanical power will obviously re-increase because ECMO has been withdrawn. And gas exchanges are ensured by the mechanical ventilation. But you see that mechanical power will be much lower compared to before being on ECMO. So what do we do to rest the lung on mechanical ventilation? First of all, we will play with tidal volume and plateau pressure on ECMO, and with the idea to reduce it. And this is based on several physiological studies, also clinical study. Today, I will not show you all the studies, so I decided to focus on just on one, which is a German RCT, which is called the Extravent study, when they randomized 79 patients, and they randomized those patients into two groups. One group, which was a control group, which is a classical protective mechanical ventilation, using 6 ml per kilogram predicted body weight. In the interventional group, it was 40 patients when they decided to decrease the tidal volume from 6 to 3 ml per kilogram predicted body weight, and to be sure that the pH and the PCO2 will be maintained in an acceptable range, they had a CO2 removal. Okay, so only difference between these two groups is the reduction of the tidal volume from 6 to 3. And they show that in this last population, ventilator-free days at day 28 and day 60 were not different between the control group and the interventional group, which was the tidal volume reduction of 3. However, what is interesting is this subgroup analysis when they focus on the most severe patient. And the most severe patient with a PF ratio lower than 150, this is clearly our target population on ECMO, so meaning those patients with the smallest baby lung. In that case, decreasing the tidal volume from 6 to 3 was associated with more ventilator-free days at day 28 and day 60, suggesting again that if you are able to specifically protect those patients with the smallest baby lung by reducing tidal volume and plateau pressure, it may be beneficial for your patient. What about the PEEP? On ECMO, usually we target a high PEEP level. Why? Because the decrease of the tidal volume lower than 6 ml per kilogram may cause pulmonary derecruitment. So we have to play with the PEEP to try to maintain open this lung as much as possible. And for that, we have several studies. We have this one, which is observational study done in Swiss centers, showing that if you compare patients who are going to survive in ICU versus those who died, patient ICU survivors had a higher PEEP level before ECMO initiation and also a higher PEEP level during the first 7 days on ECMO. And in multivariable analysis, you see that having a high PEEP level from day 1 to day 3 was the protective factor against ICU deaths and time to death in ICU. So on ECMO, we will probably increase the PEEP. So since the beginning, I told you that we're going to decrease the plateau pressure and we're going to increase the PEEP. So at the end, what I'm doing, not surprisingly, I'm decreasing the driving pressure. So what is the driving pressure? Driving pressure, it's the differential between the plateau pressure and the PEEP. And it has been shown that in this landmark paper, which is not on ECMO, but a very interesting one, showing that the higher the driving pressure, the worse the prognosis. So clearly, having a high driving pressure will negatively impact the outcome. And this graph gives you the relationship between the driving pressure and the relative risk of death in the hospital. And you see, first of all, that the higher the driving pressure, the worse the prognosis, meaning the higher relative risk of death. But what is interesting is to see that on ECMO, because most gas exchanges will be ensured by the ECMO device, and we are not relying on mechanical ventilation anymore to ensure gas exchanges, we will be able to safely decrease the driving pressure. And this has been shown also in this large international cohort when we compare in more than 500 patients the driving pressure between ICU survivors and ICU deaths. And you see that people who are going to survive in ICU had a significantly lower driving pressure before being on ECMO, but also during the first 3 days. And driving pressure in this analysis was the only one ventilatory parameter associated with a better prognosis. So it means that the lower the driving pressure, the better the prognosis. On the other hand, the higher the driving pressure on ECMO, the worse the prognosis. So which number should we target? This is not an easy task, but we can guess that based on this landmark paper, it shows that when you have a driving pressure lower than 15 centimeters of water, the relative risk of death is decreasing, is below 1. So we should target on ECMO a driving pressure lower than 15 centimeters of water. And this has been recently demonstrated based on the LSO registry in patients who got a driving pressure lower than 15 centimeters of water was much lower, 31% versus 39% in those patients who got a driving pressure higher than 15 centimeters of water. And this is true whatever the adjustment that you do, even if you adjust on the baseline severity of your patient, you will still find a better prognosis for patients who are managed with a lower driving pressure. The point that we don't know yet is that should we go further? I mean, should we still decrease further the driving pressure? And technically, you know that with ECMO, you can even go to an apneic ventilation. You don't need tidal volume because removing CO2 is very easy for the ECMO device. So it's technically possible to do an apneic ventilation, meaning only PEEP, no more tidal volume, meaning no driving pressure, and your patient is only ventilated with a continuous PEEP level for a couple of days. And this is technically possible. Is it interesting from a clinical perspective for your patient? It's not so clear now, but we have several small studies unfortunately with no strong outcomes, but physiological one, suggesting that like in this paper, suggesting that if you use CPAP, so meaning only PEEP, it may be the optimal ventilator strategy to reduce VLE, and this is what illustrated in that work when they dose local inflammation by lots of cytokines in the lung, in the blood, and they show that the lowest level of cytokines was reported with this condition of CPAP, suggesting that it might be interesting to, especially maybe early on when the inflammation is very intense, maybe it could be interesting to markedly reduce mechanical ventilation by applying an apneic ventilation and trying to avoid any tidal volume. But for now, we don't have the formal demonstration. We still need research with a better quality. So RCT, ongoing RCTs will be launched soon. And maybe we could discuss this result in a couple of years. On respiratory, the second main component of mechanical power, the first one was tidal volume, driving pressure, flow. The second main component of the mechanical power, it's a respiratory rate. And the respiratory rate should be also taken into account. We have several studies. This one, for example, very interesting one, when they compare an interventional group, which was the reduction of the respiratory rate from 30 breaths per minute to 14 breaths per minute. And the control group was a tidal volume at 345 and a respiratory breath at 30 per minute. So you see that in both groups, the tidal volume is similar. And to be sure that PaO2 and FiO2 ratio, PCO2, pH will be maintained in the stable range and also will be similar between the two groups, they add a CO2 removal. So in the interventional group, they reduce the respiratory rate from 30 to 14 and they add a CO2 removal device to maintain PCO2 and pH comparable to the control group. So the only difference between that group and that one is a reduction of the respiratory rate. And interestingly, they show that if you dose in the plasma or in the bronchoalveolar lavage, if you dose the inflammatory cytokines, again, you see that with this simple reduction of the respiratory rate, you will decrease the inflammation locally or even in the blood, which is called biotrauma. Another way that we could discuss for many time, I will just say a few words about that. Proning, it's also a very efficient way to reduce ventilator-induced lung injury. It has been shown that proning is very useful. So it could be interesting, it might be interesting to combine prone positioning plus ECMO. So this is what we do time to time in our department in order to further improve and enhance ventilator-induced lung injury prevention. However, we published recently the PRONECMO trial, which was neutral. So RCT which randomized patient into proning on ECMO versus stay on supine with no difference in terms of successful ECMO winning. So for now, it's still a debate. It's still controversial, challenging to prone on ECMO, and probably if we do it, we should probably not do it for all patients. I told you in introduction that at some point you need to let your patient breathe spontaneously because your patient will be ventilated for a very prolonged time, and we know for a while that if you have only 72 hours of inactivity of the respiratory muscle, it may rapidly lead to diaphragm atrophy and with histological lesion. So we have to find a way to preserve this function, which is crucial for the mechanical ventilation duration, for example. And one way to combine on one side to keep the control of the plateau pressure, the driving pressure, the tidal volume, the respiratory rate. And on the other side, I told you that at some point you need to let your patient breathe spontaneously. One interesting mode to combine these two objectives could be the use of BPAP or APRV. So what is BPAP, APRV? It's a pressure control mode when you set the plateau pressure, which is high pressure, the low pressure, which is a PEEP, so the differential between these two pressure, it's a driving pressure. And your patient are able to do any spontaneous breathing when he wants. So it means during the inspiratory phase or during the expiratory phase without receiving an additional cycle. So what is interesting with this mode is that you keep the control of the plateau pressure and PEEP. Spontaneous breathing is permitted, but it's not synchronized with pressure cycle, which is the main difference with a pressure control mode, for example, or volume control mode as well. Another interesting point is that you set your driving pressure at day one. You will see that the resulting tidal volume of this very short, of this small driving pressure will be very short. And if you come back 15 days later, you will see that for the same driving pressure now, the patient is able to do a much higher tidal volume, which give you some indice to say that the compliance of the lungs of your patient is improving, and which may be useful also for you to see when is going to be the right time to wean your patient. And it means that with just a glance at the ventilator waveform, you are able to see and to have a good appreciation if your patient is improving, if your patient is deteriorating, or if your patient is in stabilization phase. So just by monitoring the tidal volume. So all these mechanical ventilation setting, which are called ultra lung protective ventilation, so it means far further from protective mechanical ventilation, has been investigated in the two landmark ACTs in the field. So when you were the Caesar trial and the Eolia trials, when you were randomized into the ECMO group, it was not only ECMO standalone, it was ECMO plus this ultra lung protective ventilation. This is also what is reported, recommended by the recent ELSO guidelines based on the management and of EV ECMO. So you see that all these settings are also reported by UALSO. Do not forget that IRDS, it's a syndrome, it's not a disease. So it means that IRDS patient could be very heterogeneous. It's a very heterogeneous group with different lung lesion, different etiology, different also morphology. So we need to have a close monitoring of respiratory mechanics of this patient on ECMO. And this is the recent tendency is to have a personalization of mechanical ventilation, especially for those patients, because we know that inappropriate mechanical ventilation may lead to deleterious effect. So one way to do it first is to detect if your patient has an airway occlusion pressure. So there are several methodology to do that. These methodology are also applicable in patient on ECMO to be sure that there is no airway occlusion pressure. And then you can use some bedside tools to monitor mechanical ventilation of patient and to find what is the appropriate mechanical ventilation settings. For example, EIT, which is a belt that you put around the patient's thorax, which will give you the on live distribution of the tidal volume cycle by cycle. And you see that with EIT, you can do a PEEP titration, and at each PEEP level, you will have an approximation of what is the percentage of over dysfunction and what is the percentage of collapse of the lung. And I think you agree with me that the role of PEEP is to find the adequate PEEP to have the lowest percentage of over dysfunction and the lowest percentage of collapse. Because if you have a too high PEEP, you expose your patient to over dysfunction. If you have a too low PEEP, you expose your patient to collapse. And with this EIT tool, you can have this it's possible to have this information at the bedside. So it means that, for example, for this patient 7, you see that at PEEP 20, you have 50% over dysfunction, and then this over dysfunction will decrease when you are decreasing the PEEP level. And meanwhile, the collapse will start to appear until reaching its maximal percentage when you are at PEEP 0. So the best PEEP for your patient, this specific patient, is between just above 10. So it should be around 12 when the two curves are crossing. You can also monitor that on the screen of the EIT tool. So you see that at PEEP 20, you have lots of blue, which means that you have lots of over dysfunction. These blue zones will progressively disappear, showing that over dysfunction is decreasing. And then at PEEP 10, you have no more blue, but starting to see white zones, which is collapse. And this white zone will expand while you are decreasing the PEEP. So the adequate PEEP for my patient will be visually around PEEP 10. And what was striking in this work is to see the huge heterogeneity between patient, between optimal PEEP. You see that with PEEP 20, some patients had 0% over dysfunction, whereas others have 40% over dysfunction. So that's why it reinforced the need to have a dedicated tools at the bedside to monitor mechanical ventilation for this ECMO patient. Another way to monitor it could be the use of transpulmonary pressure, and this has been investigated in the Chinese study when they compare a transpulmonary pressure guided strategy group versus a classical arbitrary lung rate strategy group. And they show that the mortality was significantly lower in the transpulmonary pressure group, with also a higher proportion of patients successfully weaned from VV ECMO. This study should be confirmed with further trials, but it's a very interesting track to follow. Because what we don't want to have this situation when your patient is on volume control, then you awake your patient on ECMO, the PEEP is still maintained at 15 centimeter water, the tidal volume moved from 4 to 6.5, but what is interesting is that this patient was equipped by transpulmonary pressure, so by esophageal pressure, which gives you the transpulmonary pressure. So this information will provide you what is the real delta pressure into the lungs. So if you have a huge transpulmonary pressure, you have a huge swing of pressure, and this is what is shown. The transpulmonary pressure moved from 12 to 38, meaning that you have a big swing of intrathoracic pressure, and we know that it's deleterious for the lung at some point, which may lead to patient self-inflicting lung injury. So that's why you have to monitor your patient, the mechanic of your patient, when your patient is still deeply sedated with EIT or transpulmonary pressure, but it could be also interesting to monitor it when your patient start to be awake with spontaneous breathing. So as a conclusion, it's crucial to pay attention to respiratory mechanics on VV ECMO. If you do VV ECMO and do not touch the ventilator, I think it's no sense, and it will not be useful for your patient. The actual recommendation for what is so-called ultra-lung protective ventilation is to have a tidal volume reduction lower than 4 ml per kilogram predicted body weight, to target a driving pressure lower than 15 centimeter of water, to achieve a plateau pressure lower than 24, 25 centimeter of water, to decrease the respiratory rate close to 10 with low FiO2, with a sufficient increase of PEEP to prevent lung de-recruitment. There are still many questions and studies are needed. Should we go further, moving to an apneic ventilation for a couple of days? Maybe during the first days of IRS, when the inflammation is very high, when your patient will be deeply sedated anyway. Should we promote spontaneous breathing? For sure, but it's much easier to say than to do at the bedside, and sometimes we are struggling to wake the patient. And for sure, we have to monitor our patient and monitor our way to ventilate them. Thank you for listening.
Thank you very much, Professor. Really complete presentation. And we are going to proceed to the exciting part of this webinar, that is going to be the simulator. Así que todos vamos a tener una experiencia ahorita real con el simulador para justamente aterrizar varias de las cosas que nos comentó ahorita el doctor Matthieu. Y al final vamos a dejar las preguntas y respuestas. Les pedimos por favor que nos apoyen a conectar en la cajita de preguntas y respuestas todas las preguntas que puedan tener. Y básicamente este es el simulador que ya les hemos estado platicando. Es un simulador que tiene el objetivo de que ustedes puedan practicar casos reales de ECMO. Y vamos a entrar justamente a un caso donde el doctor Matthieu Schmidt va a guiar absolutamente todo con respecto a este caso. Así que pues bienvenidos a esta experiencia con este simulador que nos permite practicar mucho más acerca del conocimiento de ECMO. Listo. Ready, professor.
Yeah, so let's move to the serious game. Serious game, it's a very innovative way to learn and way to really simulate a real patient. So it looks like a room in my ICU. We have exactly the same room, in fact, for those who already came to our department. So with this serious game, you have a real patient. So you have a real patient without ECMO, on ECMO, and you can focus on the ECMO device. You can focus on mechanical ventilation. If I want to go on the ventilator, Jennifer, maybe you can show us the ventilator so I can go to see what are the settings of my patient. I can move, change the FiO2, the tidal volume, the PEEP, and you will see the direct effect on your patient on the right side of your screen with the saturation, with the blood pressure as well. Then if you go back to the patient itself, you can you can remove the sheet of the patient if you want to examine the patient. You can see if he has catheter. You can provide some medication. You can also do an echo if you need it. So with this, a very interesting tool, we are doing simulation. We are doing real life simulation with a mannequin, but we are also doing simulation with this serious game when you can ask. There are many scenarios to help you to manage this complex patient. So maybe Jennifer, after this quick information, you can look at the pupils of your patient. You can aspirate your patient to see the aspect of the secretion and so on. So it's like real life. In fact, it's real life, and you have lots of information. So maybe we can start with one scenario, for example, to see with you and to make you participating. So do we start with so we can start with patient. So a patient who is 55 years old is admitted to the emergency room for acute respiratory distress. He has no past medical history except dyslipidemia. He is married, no drugs, and when he arrived in the emergency room, the saturation was 83%, using high concentration oxygen. High concentration oxygen at 15 liters per minute. And the heart rate was on 128 beats per minute. Respiratory rate was 31. Blood pressure was 95/41. He has fever as well. Cyanotic. Patient with sweat is not doing well. The hypoxemia is getting worse and worse. So you decided to transfer this patient in your critical care unit. So the first question for you, and waiting to go into the game. It's so you have the pregunta 1, question 1. If so you are ready to start, well done. Okay, so this is a very easy question, and then we're gonna move to the next one. Jennifer, if you can go. Jennifer,
Ya están compartiendo la segunda, doctor. ¿Compartimos la segunda, por favor?
Okay, so maybe Jennifer, you can say it in Spanish because my Spanish will be very bad.
La siguiente pregunta es, el ventilador y las alarmas están sonando, el paciente está desaturando, ¿qué es lo que harían primero? What do you do first?
Okay, so as you see, your patient is desaturating. At this point, the saturation is 75 SpO2. So actually, we have just a patient ventilated in critical care. We are not talking about ECMO yet. But the first thing is how to improve this saturation a little bit, just to give you some time to react and to take the right decision. So what do you do when you arrive in the room? You increase the FiO2 on the ventilator, you increase the PEEP level, or you increase the tidal volume. So this is a very introduction, easy question. So can you vote? So most of you want to increase the FiO2 on the ventilator. So maybe, Jennifer, we can focus on the ventilator now. And okay, so you are totally right. I think the first reflex is to increase the FiO2. Increase the FiO2 just to get you time to see what we could do, and just to give you few additional saturation point to take the right decision. Regarding the increase of PEEP in this context, it might be tricky because you see the plateau pressure is already 35 in this patient. So it means that you are already at the upper limit, and probably increasing the PEEP further may deteriorate the lungs for sure with the biotrauma, but also your patient may not well tolerate a higher PEEP with such a high plateau pressure in terms of hemodynamic. So I would suggest in this context, just increasing the FiO2, increasing the PEEP will for sure lead to increase too much the plateau pressure. Plateau pressure is already at a very high level. So, and playing with tidal volume doesn't change anything in terms of oxygenation. It may change your CO2 level. Okay, so let's move to the third question. Alors, is it severe ARDS for this patient? For that we got the PF ratio, and the PF ratio was 52. Sorry, it's a 6 or 5. I don't know. 52. No, 62. So it's 62. So the PF ratio is 62 for my patient with 100% FiO2. The pH is 7.24. PCO2 is 60. So is it severe ARDS patient? So you all know probably the Berlin definition. I think it's quite an easy one. Berlin definition, which give you the classification of the ARDS with three group. You need to have bilateral opacities, like on the chest X-ray that we see. You need to have a lower PF ratio. You have a PF ratio below 300, so between 200 and 300, it's a mild, and then moderate, and it's going to be a severe when the PF ratio is below 100 with a PEEP over 5. So we are classically in this condition. We have a bilateral opacities on the chest X-ray starting for less than 7 days. We are just after 48 hours the beginning, with a PEEP over 5 in a PF ratio at 62, so much lower than 100. So we are clearly in a severe ARDS. Let's go next.
Siguiente
So the
pregunta.
patient, yeah, please.
Right, Professor. Are the
So
criterios?
I think we already discussed that. I even give you the answer, in fact. So which criteria do you need to say that it's a IRAS patient? Which parameters help you to say that? It's mainly the PF ratio less than 50, but even less than 100, it's enough to tell you that this IRAS patient is severe. The respiratory acidosis is not part of the definition. Okay, good. So most of you get the right answer. Okay, so what is the next question for this case? So your patient.
Siguiente.
Okay, so this patient has been prone, failed, and now you are wondering if you you could and you should start ECMO, and you are clearly in the indication of VV ECMO that are based on the earlier trial. So it means that you need to select an ECMO, you need to select which configuration of VV are you going to start. So with VV, you only have a respiratory support. And you know that there are several configurations. So Jennifer actually is building the ECMO device. So you can select which configuration, FEM-FEM, FEM-JUG on the right with the right jugular, or FEM-JUG with the left jugular. So what are the main configuration on VV? You are totally right. You are very good, because you have the two main configuration for VV. Could be FEM-JUG, and when we say jugular is on the right jugular, it's much easier. Having a return cannula on the left jugular could be very difficult to cannulate. So we are having a FEM-FEM. It's also a possibility, but it's not. It should not be the primary configuration because of the high risk of recirculation. This is something that we could discuss further. So if we detail how it works, can you go back to the ECMO device, to the ECMO settings? No, to the ECMO, ECMO, to the ECMO with the cannula and so on. Okay, so there you are. Okay, so we're gonna drain blood from. Oh no, okay, you already. So we're gonna drain blood from the femoral vein. The femoral vein, then the blood will go into a pump. This pump will send the blood into the oxygenator. The oxygenator will be connected to a blender, and the blender will determine the PCO2 level, the sweep gas flow, and the FMO2. So by setting the ability to oxygenate or to decarboxylate, and then the return cannula will be in the jugular, the right jugular. Okay. The drainage cannula should be in the inferior vena cava, the junction between the right atrium and the inferior vena cava, whereas the return cannula could be in the jugular until reaching the superior vena cava. Okay, and this is the classical VV ECMO setting. This is not the only one, but this is the most used setting. So we're gonna go to the main next question. Next question is about the main determinant of oxygenation on VV ECMO, and there are a couple of determinants of oxygenation on ECMO. So what is doing oxygenation on ECMO? In fact, you have the FMO2, you have the ECMO flow itself, you have the sweep gas flow, or you have the membrane surface area. So what are the key determinants of oxygenation on ECMO? Which is important to know because when you are struggling to oxygenate well your patient, you need to be able to look for the problem and to find the solution. And for that, you need to understand how oxygenation and decarboxylation are made in the ECMO membrane. So, okay, so very good. So you are right. It's a multiple choice question. So if we start with the main determinant will be the ECMO flow. ECMO flow means the higher the ECMO flow, the better the oxygenation. So even Jennifer will increase the ECMO flow. By increasing the ECMO flow, you will see on the right corner that the saturation of your patient will improve. The second determinant is the FMO2. So the FMO2 is frequently set on the blender there at 100% because those patients have very sick lungs. So FMO2 is frequently set, always set at 100%. And the last one, it's the surface area. So it means that the larger the membrane, the larger the surface of the membrane, the better the oxygenation. But when you are just starting ECMO, you are day one on ECMO, usually the membrane is brand new with one more than 0.5 meters square, so far enough to oxygenate well. So these are the three determinants, but the main one is, if we have only to select one, it's the ECMO flow, which is the main one. So now we're gonna see the next question. Next question is regarding what are the main determinants of CO2 removal in that time. What will impact on the impact on the CO2 removal? So CO2 removal will depend. What are you answering? So CO2 removal will not depend on the FMO2. FMO2 will just impact the oxygenation, the part of oxygen in coming into the membrane. It will not depend on the flow as much because you don't need very high flow to decarboxylate. But as you rightly said, it will highly depend on the sweep gas flow. So the higher sweep gas flow, the better the decarboxylation, the quicker the decarboxylation. And it will depend also on the membrane surface area. So it means that if you have a very small surface area, it will impact the ability to decarboxylate. But again, on ECMO, it's not a big issue because most of the membrane are big enough to decarboxylate, and it's very easy to decarboxylate, much easier to decarboxylate than oxygenate. So the main determinant for decarboxylation, if I have only one to select, is going to be the sweep gas, even if the surface of the membrane will also impact on the CO2 removal. So I hope you like it. It was the first case, so it's a very introduction, just to show you what we can do with this kind of education tool. Very useful for practice and for training.
Thank you very much, Professor. It was only an introduction, for sure. And we are going to run to the Q&A. Vamos a iniciar las preguntas y respuestas. Hay preguntas sumamente interesantes que queremos apoyarles a resolver. Le voy a mandar también las preguntas, Doc. Y la primera es, how to explain good control in lung protection indicators and mortality without major changes? Esa es la primera pregunta que nos hacen.
Without main changes of...
Major changes.
How to explain? Can you repeat it?
Yes. Is how to explain good control in lung protection indicator and mortality without major changes.
How to control, the best way to control is to really pay attention to mechanical ventilation setting, to control them by yourself, in using a mode when you keep the control of this plateau pressure and PEEP, and driving pressure as well. And the best way to be sure that it works and that it will change, it's also to do monitoring like I show you. So obviously monitoring is not mandatory, but it may help to do it better.
Thank you very much, Professor. The second question is about using high PEEP is also considered in pediatric patients. I know your experience is more in adults, but what do you think about PEEP?
So yeah, my work is more in adults, but I have working also with peds for research, and the debate and the rationale is exactly the same. The rationale is also to say that when both lungs are totally collapsing, the only way to maintain them a little bit open is to use PEEP. So in peds also, they are targeting higher PEEP than before being on ECMO. When you say higher PEEP, it's over 10, 12.
And do you know some protective parameters for pediatrics? They are asking.
Not exactly, but they are targeting roughly the same. Huh? It's not very different from the adults. Obviously, the tidal volume will be much lower, but it's if you do it per kilogram predicted body weight, it's close to be the same.
Thank you very much. The third question is about while it is true that keeping patients on assist control ventilation is desirable to reduce muscle atrophy with low tidal volumes and low respiratory rate, does the patient experience dyspnea? If so, how can it occur by reduce?
No, it's this is what's challenging because at some point you need to awake your patient, and for sure some of them will feel dyspneic. If they are feeling dyspneic, yeah, there are several monitoring tools that we can use, like to try to monitor the intensity of the central drive of the command using P01. It's an example, but for sure this is something that you need to pay attention. This is a very good point, and you have to accept that some days it's not a good day. You are not able to wake them because they are feeling breathless, dyspneic, and so on, despite having normal ABG. And in that case, you will resedate them and retry the next day.
Perfect. Thank you very much, Professor. And the last two question is about why is the best option femoral jugular than femoral femoral?
I mean, if you have no choice, do femoral femoral. If you know only this setting, do that as well. But with femoral femoral, you have two main issues. The first one is that frequently you are limited with your flow. And I told you that the flow is the oxygenation. Because you have two cannula in a small vessel, which is the inferior vena cava. So at some point you can't extract so much blood in a small vessels like this because you have already two cannulas. So if you are limited with the blood, you will be limited by the oxygenation. If you are limited with the oxygenation, you will still rely on mechanical ventilation to ensure gas exchanges. So you will lose the key benefit of VV ECMO, which is to reduce mechanical ventilation. And the second point is that with FEM-FEM, you have a lower effective flow because you have a much frequently, it's more likely to get recirculation because the two tips of the cannula are very close one from each other. Even if you try to maintain a certain distance between the two tips of the cannula, the recirculation is much more frequent and higher with FEM-FEM configuration.
Perfect. And the last question, and I think is really interesting, is about what do you think about awake ECMO in the early course of VV ECMO?
Yeah, awake ECMO. So first of all, you have to define what is awake. Is awake it's a patient who is breathing spontaneously with the tube? It's a patient who is not intubated at all? Is it a patient who is breathing spontaneously on trachea? So there are very lots of confusing terms in the literature, but I think it's theoretically very attractive. We have tried to do some patients who were cannulated without being intubated because for immunocompromised patient, probably it's maybe more risky to intubate them than to cannulate them. But we have also done this a couple of times, but with some failure. It means that it's a very complex interplay between the central drive of the patient, the lungs of the patient, and the device. It's like a couple. If you are two, it's already complex. If you are three in the couple, it's even more complex. So you have three players that need to play together. And at some point, those patients were complaining to be breathless and were begging us to be intubated because it was a big conflict between their brain and their lungs. And so it could be done time to time, but you have to accept that it may be you may have failure as well. But it's something which is an emerging part of the research, probably promising. Maybe in a few years we will not intubate the patient anymore. We will just cannulate them. I don't know, but it's something interesting to study.
Thank you, Professor. And the last, I promise, this is the last, but as soon as we have a lot of respiratory therapists on live in this webinar, they want to know which is the role of a respiratory therapist in the team of ECMO, and also what about the mobilization of the thorax and all the rehabilitation that they can support.
So rehabilitation, it's like any patient, I think, except that you need to have more precautions when you want to do active mobilization for them. But all patient has physio, receive physio, and early on, passive at the beginning, and then active one. Regarding the role of respiratory therapists, it's crucial. In France, we don't have this job. I mean, but I know that in US, in Mexico, it's like this. But it's very, very important job. Especially, it's just a lecture. In fact, yeah, I just said that if you don't touch a ventilator, so I mean, if the respiratory therapist is not doing his job on ECMO, I think ECMO is useless. So our job is very important.
Thank you very much, Professor. For the last, I want to invite you to the next lecture diploma in Mexico City. Professor Matthieu is going to be here. So let's go, Professor.
Yeah, so with my colleague, Professor Alain Combe, also coming from La Pitié in Paris, we are delighted to come back in Mexico City and to deliver the ECMO diploma. So I know maybe some of you already know it, what we are doing in Paris, but we will do the same in this time in Mexico City. We are invited by the National Institute of Respiratory Disease, INER, to deliver this course. So 2 days of very intense lectures, when we're gonna tackle almost all the aspects of ECMO management, VV, VA, with a diploma at the end, certification. So it's going to be done from 3 to 4, the 3rd and the 4th of March, next March, or in a couple of weeks. So we are delighted to come back and to deliver these lectures. So it's going to be 2 very intense days, but full of knowledge, full of sharing experiences on ECMO, and full discussion about your management, our management, and together, I think this is a way to improve the care that we are delivering to our patients. So I just wait for you. I will see you there.
See you soon. Thank you, Professor, for that invitation. Muchas gracias a todos. Básicamente queríamos hacerles esta cordial invitación teniendo aquí al profesor Matthieu Schmidt, y créanme que va a ser una experiencia inolvidable poder tener todas las respuestas a estas dudas que surgen y que ellos tienen muchísima experiencia. Pues bueno, va a ser sumamente interesante. Así que muchas gracias al profesor Matthieu por la excelente charla que nos dio el día de hoy. La verdad es que creo que ha resuelto varias dudas que tenían ustedes, y bueno, lo que nos interesa mucho es que siempre tengan educación de calidad con expertos como el doctor Matthieu Schmidt, que es reconocido a nivel internacional. Muchas gracias, profesor. Thank you very much, professor.
Thank you very much to you.
And queremos invitarlos a todos también al siguiente webinario. Recuerden que vamos a tener el siguiente webinario el próximo jueves a las 7 de la noche con el doctor Ismael Maldonado Beltrán, que también es parte del equipo de ECMO del Instituto Nacional de Enfermedades Respiratorias Ismael Cosio Villegas. Les encargamos mucho difundir esta información. Vieron que estas charlas están siendo sumamente productivas, sumamente educación de calidad, así que compártanlas con todos sus colegas. Son gratuitas, todos se pueden registrar, así que bienvenidos a ello y los esperamos en marzo. Créanme que va a ser unas jornadas de educación sumamente interesantes, no se lo pueden perder. El doctor Matthieu Schmidt y Alain Combe solo han venido una vez a Ciudad de México, esta va a ser la segunda vez, y bueno, queremos obviamente que tengan un gran recibimiento por parte de México, así que los esperamos a todos se pueden inscribir, no solamente es para médicos, también son enfermeros los que se pueden inscribir, terapeutas respiratorios, cualquier persona que esté involucrada en un programa ECMO debería tener posibilidad de tener acceso a esta información, así que bienvenidos todos. Toda la información que necesiten, dudas, preguntas, dudas pueden contactarnos por chat, pueden enviarnos un correo para saber informes, estamos a sus órdenes. Y pues listo, muchas gracias a todos. Les vamos a lanzar la poll de satisfacción de este webinario. Como saben, nos interesa mucho saber qué piensan de estos webinars, de saber si los están disfrutando, qué temas les gustaría que abordáramos, así que les encargamos mucho que las respondan. Muchas gracias por ello. ¿Y qué les pareció ECMO Sim? Nos encantaría también que nos contaran un poquito acerca de qué les pareció ECMO Sim. Si nos pudieran compartir aquí en el chat o compartir en redes sociales, pues su experiencia nos ayudaría muchísimo a que más gente sepa que existen estas herramientas para podernos entrenar en ECMO y que son sumamente útiles, que no requerimos una máquina, un maniquí, un experto en simulación, que se pueden entrenar con el simulador, así que todos también pueden adquirirlo. Es como una suscripción a Netflix, tal cual. Ustedes pagan una suscripción al simulador y tienen acceso por 4 meses. El simulador ya próximamente va a estar en español, lo cual es increíble para toda nuestra comunidad de América Latina, porque ya es un simulador que estamos utilizando 100% en Europa. Entonces, queremos que tengan ustedes también las mismas herramientas que tienen profesionales en otros países. Así que bienvenidos, muchas gracias por su tiempo. Excelente sábado para todos. Les dejamos las encuestas, por favor, contéstenlas, nos ayuda muchísimo a saber qué piensan de esos webinarios y si nos pueden dejar en el chat qué les pareció ECMO Sim, les agradezco muchísimo. Muchas gracias a todos.